Hi, everyone. I see that the numbers of attendees are rapidly going up, so we're at 66, so I think we'll get started. For those of you who might be in the wrong room, this is the panel session on approaches and challenges for adapting humanitarian responses to the reality of the COVID-19 epidemic. So welcome to all of you. Great to have so many people here. My name's Tom Ellman. I'm the director of Médecins Sans Frontières Southern African Medical Unit, SAMU, based in Cape Town. We're a unit that focuses on HIV and TB, but like so many others, we have been diverted fairly extensively in the last 6 months to responding to this new virus, COVID-19. And I'm here to welcome you to the event and act as a chair for this evening. So thanks to you all for joining us. And before we start, a little housekeeping before we kick off the main event. We're recording this evening's event to share with those who are unable to join us live. And we would like you to be part of the discussion today. So we're encouraging you all to get involved in the conversation. There are 2 ways you can do this. I hope most of you have been on more than one Zoom in the past, so you may be aware, but I'll repeat it. You can use the chat function, and please do now as much as possible to introduce yourselves and to network with other attendees. And please use the Q&A function to put questions to the panel. We won't be able to unmute and to have everybody asking their own questions in the interests of time, but if you could put your questions there at the end of all the presentations, and we have 5 presentations, I will ask these questions we'll have an hour, hopefully, almost, for the discussion. So please do put your questions there. But if you have urgent clarification questions, highlight those and I'll put them straight away in between the sessions. So please do remember, put your questions in the Q&A, not in the chat, if you would like them to be put to the group. And if they're directed to a specific person, please include their name. So I'm excited to be joined by a fantastic panel who will be bringing different insights and discussion points on how humanitarian programs and contexts are integrating the need for COVID-19 prevention, screening, testing and care in the delivery of humanitarian assistance. I won't read the biographies of all the panelists, but you can see them online at the link to this event. And I'd like to hand you over now to our first panelist, Dr. Janet Victoria Diaz, Team Lead for Clinical Management, Infectious Hazard Management on the World Health Emergency Programme at WHO, who will give us an overview of WHO guidance on integrating the COVID health response in low-income settings and humanitarian settings. Please, Janet.
Thank you, Tom, very much. Sorry, I'm having my slight technical issues here. So it is my privilege to have been invited to participate in this very important conference. And I just want to thank the meeting organizers, obviously the colleagues from MSF, as well as the Liverpool School of Tropical Medicine and the University of Manchester. And so I did prepare 5 slides. I was told I can give 5 slides, and so I do have those. So let me see if I can get them up on the screen here. And I think you can see that. All right, as discussed, I am the lead for the clinical management response for COVID-19 here at WHO in Geneva, part of the healthcare readiness unit and part of the health emergency program. So in that, have been involved in other responses, most recently in the Ebola response in North Kivu, DRC. I was asked to discuss a bit about clinical guidance and how that interplays with the humanitarian response and the context. And I think when we conceptualized our clinical guidance for COVID-19, in a pandemic for a new virus, obviously there's tremendous uncertainty. And I think regardless of where you work or where you are and what your job is in the health system or in the public health system, that the uncertainty that we've had to practice within is complex, and it has added many questions and fears to not just the community that you're serving, but also to yourselves, to the workers, on how do we manage these patients? What do we do? You know, and as we started to learn more about the disease, which we've learned a ton over the past 9 months, due to the great work of many researchers around the world and patients who have agreed to enroll in research studies, that we've able to advance our guidelines. But even when we go to, and I will speak a little bit about therapeutics, I think what we all know is that doing the basics well is what matters most. And so we published this COVID care pathway, I think in May, and really it was just to emphasize that a COVID care pathway can be implemented in any setting. It has to be adapted to your setting, but the highlights of the process don't change, right? So what is it that we start with? We start with screening for patients with COVID, and that can be done again at any part of the healthcare setting. What is involved in those screening questions has evolved over time as we've learned about patients' symptoms. First, we thought they were typical symptoms, and now we know about the atypical symptoms, et cetera. But that process of screening and early detection of a possible patient who may be suspected for COVID is important. We also know that following that some patients, not all, but some patients may be very sick. And so triage, which is an acuity-based triage to find those patients that are sick, those patients that do need some emergency intervention or potentially a very urgent intervention, is important. So that, and this is regular part of clinical practice, and this has to continue on for patients who have suspected COVID. But what happens is in this pathway is that you all of a sudden activate, the reason that the pathway is important, that you activate the right IPC, right? That you activate the right, that the patient gets cared for now in the right place of the hospital or in the right room or in the right outdoor space. And that all health workers that go into contact with patient wear the right PPE. So I think that's the premise of the pathway, that you screen, you activate IPC, and then you go along with your usual care. The clinical assessment. Now, for COVID, that becomes as well, who is sick and who is not sick, who needs oxygen, who has, you know, some warning signs of a severe clinical condition, could be severe pneumonia, respiratory distress. We also now know, we didn't know at the beginning, but we now know it could be a symptom of delirium or complications such as stroke that patients may be presented with. So that clinical assessment is key important so that you can risk stratify your patient. We know patients now who are at high risk for severe disease. We also know that those that aren't. But then in your system, you can give them treatments, and that treatment will depend on what setting you're working in. So where have you chosen to care for patients who are very sick? Where is that hospital? Where is that health facility? What capacities does that have? Or where are you choosing to care for those that are mildly ill? Are they going to be cared for in a facility, or are they going to be cared for at home? Or are they going to be cared for in a temporary setup in a gymnasium or a community facility? These are decisions that have to be made at the local level or at the national level, or sub-regional level, but the pathway needs to be clear and the referral pathways need to be there. And then release from pathway. When is it safe from the IPC side, as well as from the IPC to leave the IPC pathway, and then from the clinical side, when can you go home? So for me, the COVID care pathway, which you can find on our website, was really something that can be implemented in any setting, adapted to that setting. But again, emphasizing that doing the basics well is what's most important. Therapeutics, you know, I don't even know how many clinical trials are on clinicaltrials.gov right now, looking at various interventions to see what reduces mortality. And unfortunately, there hasn't been a lot of therapeutics that have shown to be beneficial, but actually, to be honest, what we do have, and I think I'm just going to highlight our clinical guidance that is also available on our website, is what we do have, and this is a very simplistic infographic, but also highlights the importance. What we do have is corticosteroids, and we do have now strong evidence and a strong recommendation in favor of the use of corticosteroids for patients who have severe and critical disease. Fortunately, corticosteroids are widely available. They are inexpensive and can be given both orally and intravenously. So this, a simple medicine, and we are very happy that this was tested in robust clinical trials, found a benefit. We recently published on last Friday, our recommendation on remdesivir, now a more complicated and expensive antiviral. And we actually, based on meta-analysis data, recommended against the use, a weak recommendation because more trials need to be done in subgroups, but a weak recommendation overall in patients of all disease categories. But what's coming up in the pipeline? We will see. WHO is developing guidelines based on a living guideline mechanism that will take new evidence, synthesize, and then write a recommendation. Now, we won't write the recommendation on press release, meaning just because a study says, or some company may say this reduces life, we will wait for the data and we will synthesize the data and we will convene an independent panel to review the data and discuss the harms and benefits, the feasibility, the resources, all these issues in order to give a holistic recommendation for policymakers and for clinicians. But as we know, a magic bullet is not the answer, right? We know there's not going to be one thing that's going to just save lives. In caring for severe COVID patients, what we've encountered, and this applies mostly to settings that are more fragile, that oxygen is not widely available in some of the most complicated settings. And that, I think, is a big challenge. So working with partners, WHO set up the global supply chain system, which was meant to try to secure the market so that oxygen concentrators, pulse oximeters, monitors can make it to patients, as well as more advanced respiratory support interventions, but I think from such as ventilators. But what I want to emphasize here, that oxygen was actually the #1 intervention, the one that were in supportive care intervention, and concentrators, getting those to the field was also the #1 intervention we worked on with partners, including MSF in this global supply chain consortium, as well as many other partners. And then we've started to work more on scaling up of oxygen. And this is also complicated. So here is just a complicated graphic of the support that we're providing to countries to scale up strategic planning, procurement, and scaling up meaning not just concentrators, but real proper oxygen systems such as PSA plants. And getting those, how can we get those to hospitals to care for patients? And so this is a novel thing which is ongoing, that we've convened 3 or 4 technical consultations with experienced entities, and again, acknowledging MSF's participation in this, as well as other agencies, that we are really trying to write some operational guidance that looks at the challenges and solutions in order to accelerate oxygen scale. This is not a problem. COVID has highlighted this problem, but this problem is not a new problem. This problem has been going on for decades. And we know that death from pneumonia, severe pneumonia in children under 5 remains a high burden of disease. So this is, again, we are now taking this opportunity to press this issue in order to improve the availability of oxygen. I also want to highlight some work of my team, my multidisciplinary team, because we work as multidisciplinary. So I'm a clinician, a pulmonary ICU doctor by training, but my good colleagues that work in that are more on the engineering side and on the technical side have developed a technical network. And this network is really working to improve designs of facilities or repurposing facilities to ensure safe IPC pathways and safe ventilation. And so this, I just wanted to highlight a multidisciplinary work on, right now, it's a research project on how to improve the guidance and make it more usable for doing safe home care and self-quarantine and isolation in high density population settings. And this is an effort with networks, which means university academic networks from this TechNA network, as well as WHO and other partners. And finally, in order to disseminate information, I just wanted to flag here our clinical management training materials, and these are available online, always increasing in their scope and quality as we try to keep it updated with our guidelines. And the Academy app from WHO that also has this available, but just really to acknowledge how important it is to train staff and to keep staff skills up, and not just in clinical care. I really want to highlight again with my colleagues from the biomedical technical world, the true importance of having biomedical technical expertise in these settings, because when you start to manage patients with COVID that do require oxygen and do require devices, consumables, those sorts of things, and potentially the small percentage that may require ventilation, that type of expertise, not just clinical, but also biomedical engineering expertise is available in order to upkeep, maintain functionality of any piece of technology that goes to the field. And one last slide, and then done. This is our clinical data platform. The understanding of the disease in different settings is important. Most of the information we have has started off in more high-income settings, obviously the United States and in parts of Europe and in China. But how does the disease look like in other settings? What does it look like in the Afro region? What does it look like in some of the more resource-limited? Is it the same disease? Is the phenotype different? And this is the clinical data platform that WHO hosts in order to give capacities to countries to collect their own standardized clinical data so that they can also look at their own clinical characterization in order to guide their response. So with that, I want to say thank you for this opportunity, and I look forward to the rest of the meeting.
Thank you. Thank you so much, Janet. That was great. You've set a standard for keeping to time, so all the others now have to follow. We've had one excellent reminder to all of the panelists of the need to remember not everyone is medical. And Janet, I didn't think you overdid it on the acronyms, but let's make sure we are aware of that and clarify any complex abbreviations or acronyms. I think also the reminder that we need to go away with to do the basics well is something that's going to keep coming back. And our other presenters will be talking more about how we adapt and what those basics are as we have the shifting sands of the epidemiology and the knowledge about COVID. So next up, to tell us a bit more about approaches to adapting to the COVID-19 in resource poor settings and humanitarian programs, we have Dr. Raji Tajudeen, who is Head of Division of Public Health Institutes and Research at Africa CDC. Raji, please go ahead.
Right, thank you so much. Tom, let me try and share my slide. Yes, can we all see the slide? Hello?
Yes,
yes, we can see it.
Okay, perfect. So let me just go straight. So I will frame my discussion around what we've done as Africa CDC to respond to the COVID-19 pandemic collectively as a continent, which I mean, it's something that a lot of credit has been given to the African Union and Africa CDC for taking the lead as far as COVID-19 pandemic on the continent is concerned. So let me start with what exactly is the current situation as far as the continent is concerned. Today, we are over 2 million cases and we have over 50,000 deaths. The good news here is the fact that more than 84% of our cases have actually responded. So if we unpack the trajectory further, you will see that we gradually move, that's sometimes mid-July, from 18,000 cases per day to around 7,000 cases per day by mid-September. And of recent, we have begun to see an upward trend again, which is looking like what is happening in Europe and in America. So as far as our timeline for the response on the continent is concerned, I've tried to just outline what exactly we've done since the first case was reported on the continent on the 14th of February. A week after the first case was reported, we convened an emergency meeting of our ministers of health from all the 55 member states. And it was at this meeting that the the continent-wide strategy for COVID-19 was endorsed and approved. At that same sitting, the task force to drive the continental strategy was equally approved. And that meeting did emphasize the need for coordination, collaboration, cooperation, and communication. And this has really, really assisted as far as responding to the situation on the continent is concerned. On 21st of April, when we did some assessment, we discovered that the number of tests that was being done on the continent was nowhere near what is expected to fully define what exactly is the burden of COVID-19 on the continent. So at that time, as a continent of 1.2 billion, we were doing a test of less than 250,000. So this was what informed the launching of an initiative called Partnership to Accelerate COVID-19 Testing on the Continent. And one of the key targets of that initiative was to carry out 10 million tests as a continent within a period of 4 months. And we did achieve that target exactly at 3 months. And today we are at over 20 million tests on the continent. Of course, we also did realize that the COVID-19, to bring it under control, we need a safe and effective vaccine. And we know that equity, affordability, and asset itself is going to be a big challenge. So in the last week of June, we did convey a meeting of the leadership of our continent to discuss the issue of COVID-19 vaccine. And one key thing at that meeting was the need to bring everybody on board, all the relevant stakeholders, from our community leaders to the civil society organizations, to the different partners as far as the continent is concerned. And that meeting gave birth to Africa COVID-19 vaccine development and access strategy. And underpinning this strategy were 3 key objectives. One is for Africa to be part and parcel of the clinical trial that will come up with the COVID-19 vaccine, and also to be part of the manufacturing of this vaccine. 2 is to ensure that Africa has access to adequate quantity of this vaccine so that we'll be able to vaccinate 60% of our population that will give us the needed herd immunity. And of course, the third aspect of that strategy emphasized on regulation, uptake, delivery and uptake, because it's one thing to have the vaccine, it's another thing to have, the uptake of this vaccine by the community. We know now that the COVAX facility is there and they are ready to, assist, but the COVAX facility is not going to give everything. For instance, on the continent, we know that COVAX facility is going to give us 20% of what we need, and 60% is what we actually need. So for the remaining 40%, we need to look inward. We need to come up with a complementary approach that will allow us as a continent to be able to mobilize resources that is needed for the 60% of our population to be covered. And in this regard, the head of state and government of the continent, under the leadership of President Cyril Ramaphosa of South Africa, has put in place what we call COVID-19 African Vaccine Acquisition Task Team that will mobilize needed resources for this 40%. So this is the meeting that took place just a week after the first case on the continent was announced, and this brought together all the 55 embassies, ministers of health. Again, this is the strategy that's driven what we have done as a continent, that has allowed the cases we have on the continent today to be at less than 4% of the global total cases, and in terms of death, we are just at 3.5% of the global total. So our strategy is underpinned by 1, prevention of transmission, and this requires enhanced and effective surveillance, and of course, for us to be able to have access to vaccine that will limit viral transmission. Number 2 is prevention of death. So this emphasizes the need for effective case management. And for us to be able to manage effectively the cases that crop up on the continent, we need adequate medical supply. Colleagues, you agree with me that one of the biggest challenges as far as this COVID-19 is concerned is access to medical supply, equitable and affordable access. And of course, vaccine will also go a long way. And third, on the on our strategy is the need to prevent social and economic harm. We know that different member states put in place different lockdown measures with a lot of humanitarian consequences. So today we are happy to inform you that through the leadership of African Union, we have been able to launch a campaign that is allowing us to harmonize, and as much as possible to limit whatever consequences or socio-economic harm that results, that will result from these different lockdown measures. So as part of our partnership to accelerate COVID-19 testing on the continent, we did put in place a pool procurement platform. And with this platform, a lot of the member states were able to have access to the needed medical supplies, ranging from mechanical ventilators to oxygen concentrators to test kits to personal protective equipment and so on and so forth. And through this initiative, we're able to support member states with the needed community health workers, because we knew right from outset that this pandemic has come to stay and it will require us to beef up the capacity at our primary healthcare level. And community health workers' agenda continue to be one of the key approaches or key measures Africa CDC has deployed to respond to this COVID-19 pandemic. Again, this is a summary of the different trainings we have conducted on the continent. Let me emphasize here that at the outset of this pandemic, there were only 2 labs on the continent that could do COVID-19 testing. These were South Africa and Senegal. Today, we are happy to inform you that through effort of Africa CDC together with partners like WHO, the entire 55 member states today have what it takes to diagnose COVID-19 or SARS-CoV-2 on the continent. And for other key pillars of the response like surveillance, IPC, risk communication and community engagement, case management, public health emergency operations center, we have built the needed capacity in each and every member state. On the right side of the screen is the different medical supplies that we have provided to members, including therapeutics. We did distribute about 9 million doses of dexamethasone to support our member state to be able to manage the severe to critical cases of COVID-19. We have also built the genomic sequencing capacity of our member states so that we are able to define exactly what is the strain that is circulating on our continent, where is this strain coming from, and what changes is taking place as far as this strain is concerned. Again, in terms of our human resources, so this is the member state that we have supported one way or the other. So on the left side of the screen, this is our epidemiologists. We have supported member states with epidemiology, about 188 all in all. And for community health workers, we have supported member states with close to 10,000 community health workers to be able to respond to the COVID-19 pandemic on the continent. So this, the vaccine development and access strategy that I talked about, and those are the key objectives as far as the vaccine strategy is concerned. So to conclude, one thing that's actually shaped the way Africa has responded to this pandemic is that of coordination and under the highest political leadership on the continent. And this has really helped. So this is a key lesson for us so that whenever the next pandemic comes knocking, we know how to approach this. Number 2, the COVID-19 pandemic has also, teach us that we need a new public health order as far as the continent is concerned. And when I say a new public health order, what I simply mean is that there is need to strengthen our public health institutions. We know that some member states do have national public health institutes. So this is time now to begin to advocate and support member states to have in place what we call a national public health institute. So this is like US CDC equivalent in each and our member state, and Africa CDC is ready to support member states to put in place such institutions. We need to build our local manufacturing capacity as part of the new public health order. We need to strengthen our workforce capacity on the continent as part of the new public health order. And of course, much more importantly, data governance is key, and partnership. All these very, very important. Workforce, I've emphasized that. And of course, local manufacturing capacity, I've also talked about that. So colleagues, to conclude, COVID-19 is still very much with us in Africa. So we continue to emphasize the need to continue to put in place and deploy the different measures that allow our cases to remain low on the continent. Thank you.
Thanks very much. Very interesting and a real baptism of fire for Africa CDC. Amazing to get the insights into how you've been developing an approach across the continent. Just a reminder to the participants, please do put your questions into the Q&A. I'm sure you have many, so by all means keep them to the end, but you can also put them up onto the Q&A section now for later. And also, if any of your fellow LEAP students haven't joined, do send them WhatsApps and message them to tell them what they're missing and see if we can get everyone in on the call. We're now going to move to Dr. Tom Wingfield, consultant infectious diseases physician and senior lecturer at the Liverpool School of Tropical Medicine. And Tom's going to speak to us about COVID-19, healthcare workers and health systems, looking at Liverpool, Malawi and Vietnam. So we'll see how he brings those together, and a cautionary case of tuberculosis. Please go ahead, Tom.
Hi, everybody. Tom, can you hear me okay there?
I hear you fine.
Brilliant. Okay. Hi, everybody. It's a pleasure to be here. And thank you very much to Tom, to Roger, to Lucy and the LEAP team. I'm delighted to be here with you today. I'm Tom. I'm an infectious diseases physician and a researcher predominantly in tuberculosis. I currently work clinically in Liverpool in the UK, but have worked clinically in other low-income settings and also in research. So I'm going to talk to you today with a focus about healthcare workers and the impact of COVID-19 on health systems, and see how we can apply lessons from Liverpool and other low and middle income countries as well today to our learning. I'm also going to use, tuberculosis as a case study to think about how health systems can be distorted by COVID-19. So the way that I'm going to do this is run you through our experience of the first COVID wave in Liverpool, and then talk about the current COVID wave that we are going through, thinking about how we can exchange knowledge about what we've learned. And in between, I'll try and cover issues to do with our partners in Malawi and oxygen, as Diaz has already mentioned. I'll look at things to do with social protection and how finances can influence people's risk in Vietnam. I'll talk to you about TB, and then I'll mention some of the work done by colleagues in the ARISE consortium, which is led by Liverpool School of Tropical Medicine. So back in April, we wrote an article, myself and Prof. Tetmeyer, one of my colleagues at Liverpool School of Tropical Medicine, of the things that we'd been experiencing in Liverpool's first wave. And I think this is relevant to most places around the world. We found that the risk to healthcare workers was high, of infection, of sickness amongst families, and also staff sickness of being off work due to COVID-19. And as has been seen in other outbreaks such as SARS and MERS, we found that there was impact on mental health, anxiety, depression, in some cases post-traumatic stress disorder, and sadly suicide amongst healthcare workers related to COVID-19. We had issues in our local hospital with personal protective equipment, PPE, and a lack of testing at that time for frontline healthcare workers, which really made things difficult on the ground. And as for all of us in healthcare, we had to really undergo a massive period of rapid learning, which was difficult to keep up with. And we had to upskill or change our skills to different areas. For example, use of ventilators for those of us who may not have used them before, which was sometimes outside of our comfort zone. And clearly, we also faced, thankfully, not hugely, but we did face issues with resource allocation. And that can sometimes lead to very difficult decisions to be made, especially for the sickest patients. Whilst we were dealing with the COVID-19 first wave in Liverpool, we have partners in Malawi, the Malawi Liverpool Welcome Centre, that also has links with Queen Elizabeth Central Hospital in Blantyre, Malawi. And as Diaz has mentioned, oxygen is actually one of the key features of COVID-19 treatment, alongside things like dexamethasone. And our colleagues in Malawi were able to actually increase or decrease, I suppose, the time to development of a new critical care unit. At the top there is the old unit in Blantyre, Malawi, and below is the new unit with some funding from the Wellcome Trust. And this is in a setting in Malawi that have had 16 working ventilators in May 2020 across 4 central hospitals. That's about 1 per 1 million population critical care beds. And so I think it also highlights the need, as has been mentioned in the other talks, the unmet need for high dependency and critical care, but also difficulties in getting an uninterrupted oxygen supply. And the team did manage, with a really innovative co-partnership with an engineering company and also a charity, to get a concentration plant set up in Blantyre, Malawi, which you can see there being inaugurated by the minister, plus acquisition of suitable PPE. So I think that these huge scale changes to try and deliver these are achievable, but clearly they do require resources, finances, and additional infrastructure. I'm part of a network called the Social Protection Action Research Knowledge Sharing Network, SPARKS for short. And actually some of what we were doing was looking at Vietnam with colleagues in Vietnam as a case study for how COVID-19 impacted on people's finances. We saw Dr. Raji Tajudeen's talk mention not just about medicines, but the social and economic harm that can be done by COVID-19. And we looked at the individual and household level impact of the COVID-19 pandemic. And Vietnam is a good case study in terms of it does have existing inequalities, but it has social protection packages and has previously been affected by SARS and avian influenza. The out-of-pocket costs for healthcare were already large and actually increased during the course of the pandemic. Here there's people actually trying to get masks and PPE, and the price of these goods, which is out of people's pockets, increased 3 to 10-fold during the first wave of COVID back in the first half of the year. There was also huge problems with obviously restrictions to travel and shutdown of work. And here you have farmers who are hugely affected by closure of borders, having crops that either sold at low cost or were lost. And that reduced income has a huge impact for people, especially in informal and low skilled work. It also has an impact on what people can afford to buy in terms of food, which again may have an impact on healthcare access and health itself. And we find that the poorest households fall into the COVID-19 poverty trap, in that they are most at risk of COVID-19 and most at risk of ill effects from COVID-19. But Vietnam government did actually put in place a $2.6 billion US package of cash transfers for some of those poor households to try and be able to meet their need. But clearly in some of those programs, there's misclassification of people who are not classified as poor, whereas others, such as migrants or internal migrants, may be unable to access those packages. But I know that's being covered in a later talk. I'm a tuberculosis researcher and also physician. I just wanted to raise the cautionary case of tuberculosis. So this was back in March. We brought up on World Tuberculosis Day the impact that COVID-19 was going to have on TB. TB is the archetypal disease of poverty, and actually will probably kill a similar amount of people to COVID-19. So COVID-19 has killed 1.5 million people so far this year, and last year TB killed 1.4 million people. And the impacts of COVID-19 can be felt on TB disease. So the impacts in terms of poverty and malnutrition that we mentioned will lead to an increased risk of tuberculosis. There will be decreases in healthcare access that will affect TB case notifications. And the outcomes of people with TB will also probably be impacted because they're unable to engage with treatment. We've seen this reported on in other areas, and this was also reported on by WHO and the Stop TB Partnership, who found that TB case notifications were down by 75 to 80% during this first wave of the pandemic in places like India, China, and Pakistan. And that people were not being able to engage in directly observed therapy of TB, that there were stockouts of medications, and that there was repurposing of TB laboratories and clinics to deal with the COVID-19 pandemic. This also has an impact on things like immunizations, including BCG. There were some positives to come out from this. In the bottom left article there from Pakistan, they mentioned in the Zero TB initiative city of Karachi that they were using mobile vans to screen for tuberculosis and COVID-19 and do contact tracing of both of those in people who had respiratory symptoms. So I do think that there are positives to come out of this. But as we can see on the ground here from Uganda, this is a real-time survey of TB case notifications in Uganda, and we can see that they were reduced in March there when lockdown measures were put in place by 50%, a huge reduction in TB cases. And we also know from modelling studies here in low and middle income countries that the impact on COVID-19 mortality is likely to actually increase TB deaths by about 20%. Approximately in low and middle income countries through some of the mitigation and suppression strategies that are being used there. So TB is a good marker and indicator of what will be happening to health systems. And we could use that for what's going to be happening, for example, with people with diabetes, hypertension, other non-communicable diseases, which you'll all be familiar with dealing with. I'd just like to mention my colleagues within the ARISE consortium, who ARISE is a consortium that works in India, Kenya, Bangladesh, and Sierra Leone. It works with communities on health and accountability in urban informal settlements. And just to pick up on some of the issues that they found during the COVID-19 pandemic, through working with their partners, they found food security was a huge issue. There were pressures on water and sanitation that were exacerbated. Access to healthcare was reduced. And also they found increases reported of violence and gender-based violence. They also suggested that public health messages were extremely difficult to follow in some of the urban informal settlements with shared toilets and difficult access to water. So these are issues that we must take into account. And we know now there's evidence coming through with better testing that in slum areas, on the bottom three here, versus non-slum areas, this is in Mumbai, India, the rates of COVID-19 seroprevalence, so having had COVID-19, are about 54% in these Mumbai slums versus 16% in areas of Mumbai that are not slums. So we are getting indications that in these overcrowded informal settlements, rates of COVID-19 are likely to be much higher, but this is limited by inadequate testing often. But how can communities respond to COVID-19? I'm coming to the last few slides here. Well, again, work with ARISE. This is work with Dalit waste community workers in India who are also getting involved in food aid. On the bottom there in Kenya, there's working with communities to brainstorm about how to overcome some of the issues that are faced. In Sierra Leone, there were food aid stations and hand wash stations as well set up for vulnerable people in the community. And we also were able to contribute to videos that gave advice to people living in those settlements after consultation with people in the settlements that was felt to be more locally appropriate to those regions. So to bring us back to Liverpool, we've been through a really hard second wave of COVID in Liverpool. And you can see there that from September up to November, we had a huge rise in the total beds being occupied by people with COVID-19. And it put a huge stress on our hospitals, which were over capacity and actually at breaking point. And again, my colleague and I wrote about this, and just to give you some of the issues that maybe you are going through as well, as we saw the kind of second peak in sub-Saharan Africa that was shown earlier. Staff are tired. We've had cancelled leave. We've had no chance to reset. And some of us are anxious and stressed and fearful. And I think it's okay to admit that. We know that there are issues with staffing and recruitment, even in the UK, with incentives to be recruited. But we also know we still remain at risk. Households of healthcare workers in the UK are 3 times more likely to have been affected by COVID-19 than those without. Healthcare workers are affected by obviously death, unfortunately, due to COVID, but also long COVID, and people are off work with COVID. We find that hospitals that are near capacity have limited ability to triage, difficulties with the safe flow of patients. And we're also finding now that across the country, there's differentials in terms of which country, parts of the country affected most. And we're worried about that in terms of the winter pressures that we might see with flu co-infection. If you're in other settings, that goes for, you know, a rainy season or malaria season, and also HIV co-infection, which in one of our UK cohorts was shown that in some of the younger patients, actually there was an increased risk of mortality with HIV in the Isaric cohort. Finally, just to say that we have seemed to come through that second wave, and I think it's important to reflect amongst us, and that's why this is extremely important, what we're doing here now, exchanging knowledge about COVID-19. This is a map that the kind of larger expanded areas are those that have been currently shown to have the most COVID cases. And this is quite different to maps that we might see for poverty or other infectious diseases. And that may be due to immunity, lockdown measures, testing, median population age, or environmental factors. But I think it's vital that we exchange this knowledge south-south, south-north, north-north, east-west, across sectors, whatever way we can to try and learn what's locally appropriate and feasible and acceptable on the ground, and how we can engage our local communities. Because there will be future waves of this. I don't think I don't think that it's controversial to say that this will be endemic now, and so we need to deal with this going forward in lieu of an effective vaccine and the infamous herd immunity. And I think it's really important, just as Tom said, to ensure that we all do the basics well. Thank you very much.
Thanks a lot, Tom. Amazing. That's a romp through the breadth of the global, this unique acute emergency that the whole world is facing, but also reminds us both of the similarities and differences in how the impact and the response are moving. So good to see some questions coming in. Keep them coming. We haven't had any clarification questions, which speaks to the clarity with which our presenters are explaining their presentations. So we're now going to move to Reem Mussa from MSF, and we're going to move in a little bit more to classic humanitarian settings in the last two presentations. So Reem is the Humanitarian Affairs Advisor on Migration with MSF Operational Centre Belgium, and she's going to reflect on COVID-19 related challenges and adaptations of the humanitarian response for migrants while on the move, upon disembarkation, and in detention centres in a variety of settings where MSF is working. Welcome, Reem.
Hi, sorry, I'm going to be the classic person that's going to struggle to find the share screen. Sorry, bear with me. Oh, here it is. No. Sorry, 1 second. Great, I think that's working now. Thank you, Tom, for sharing the presentation, and thank you to Tom, Janet, and Raj for coming before me. I think many of the things that I will highlight in my presentation will be quite complementary to the issues that have been presented by our colleagues so far. Sorry. Yeah, so the mantra "leave no one behind" has been said many times in relation to the global response to COVID-19. However, migrants and refugees remain amongst the most exposed and amongst the least protected. In my presentation today, I'll highlight some of the difficulties faced by migrant communities due to COVID-19, but also due to the government's responses to migrants in the pandemic, as well as highlight some of the ways in which MSF adapted its interventions and advocated for migrant communities over the past year. So MSF set up targeted COVID-19 responses for migrants, often working with partners in over 30 countries, including countries like South Africa, Lebanon, Syria, Bangladesh, France, and Brazil, and the USA. The context we worked in ranged from refugee camps to reception centers to cities and at sea. And we reached all sorts of different types of migrant communities, including migrant workers, asylum seekers, as well as those still traveling to places of safety. The contexts that we worked in were diverse because the needs of migrants and the settings in which you find them are diverse. So some of the key things that impact migrants, and I think this is really well highlighted by the presentations before me, is that COVID-19 has amplified structural inequalities and vulnerabilities in our societies, especially those faced by vulnerable groups such as migrants. Migrants and other people living in informal or difficult settings are not any more likely to transmit COVID-19 than the general population. However, they are less protected and more exposed. Pre-existing vulnerabilities such as poor and crowded living conditions, lack of access to clean water, sanitation, and inadequate healthcare already have a long-standing negative impact on migrant health, and in the pandemic even more so. Additionally, protective measures such as social distancing and basic water and hand hygiene are near impossible to implement in many of the settings that precarious migrants live in. We also saw that emergency measures such as lockdown resulted in disruptions of essential support services, not only health services, but also education, psychosocial, cash assistance and transportation services, which amplified existing needs and in the reduction of assistance. And dangerously, we saw an instrumentalization of border controls and travel bans and quarantine to really conflate migration control agendas with public health agendas. So for example, during the pandemic, at least 167 states introduced border closures, and of those, 57 made no exception for people seeking asylum. Many countries suspended asylum procedures indefinitely or implemented measures such as offshore quarantine and processing. So migrants during the journey experienced many barriers during the global pandemic. As I highlighted earlier, border closures and travel bans have a big negative impact for migrants seeking protection and asylum. States use the pandemic as an opportunity to increase migration control measures and block life-saving assistance. In the Central Mediterranean, European states such as Italy and Malta declared that due to the COVID outbreak in their own countries, their ports can no longer be classified as safe places for those rescued at sea. Meanwhile, returns to Libya continued. They also impounded and blocked NGO search and rescue vessels and often cited health security concerns as a reason. And then they also introduced offshore quarantine for migrants rescued at sea on ferries docked a few kilometers away from ports. MSF obviously called for a continuation of life-saving assistance, search and rescue, and critiqued the use of quarantine vessels, advocating for safe disembarkation and implementation of protocols for health screening and quarantine and reception facilities. Fortunately, on August 22nd, we were able to relaunch our search and rescue activities with Sea-Watch, but had to adapt the way in which we did it in other years, introducing new IPC protocols on board and health screening for COVID-19. In the first 48 hours of the first rotation, we're able to save more than 200 people from 3 different rescue incidents, showing the dire need for search and rescue vessels to continue during the pandemic. Meanwhile, in Lampedusa, an island off the coast of Italy, MSF teams supported and trained the local MOH to implement protocols for health screening for disembarkation of migrants arriving on the island with small boats to help them identify COVID-19 and other medical vulnerabilities and safely allow them to stay in reception centers on the island. During a 2-month intervention, we supported the training of several doctors and nurses, but also the disembarkation of over 5,000 people on 200 boats. Meanwhile, in countries in North America, such as the United States, borders were closed to all asylum seekers traveling through Central America and Mexico, and all asylum procedures were suspended. but deportations continue to Central and South America countries like El Salvador and Mexico. So MSF scaled up our responses to migrants trapped in Mexico or returned to El Salvador. We increased our medical activities in Matamora camps, which is a camp along the US-Mexico border, by providing mobile teams, providing multidisciplinary care, both medical and mental health care, as well as health promotion. We also supported 72 migrant hostels that are kind of positioned along the routes in Mexico in several cities, from Tijuana to Mexico City, to do trainings with staff in the hostels, set up isolation areas within the hostels, and help implement better IPC measures in these shelters, as well as providing mental health care for migrants and staff within the hostels. For many migrants living in reception and detention centres, crowded living conditions for migrants at risk for contraction. The following photos are from the EU-supported hotspot in Moria, called Moria on the Greek islands of Lesbos. At the beginning of the pandemic, nearly 20,000 people were contained in the Moria camp, which is built for 2,700 people. Wash services are completely inadequate and well below humanitarian standards, with 1 toilet per 60 residents, and water supply only available 5 to 6 hours in some area of the camp. As MSF, we quickly adapted our health response that was pre-existing on the island. We set up a medical triage zone with other medical NGOs to ensure a proper health screening and continued access to essential medical care. We also set up an isolation centre for suspected cases with 40 beds, which we unfortunately had to close due to administrative and political reasons. We advocated for the evacuation and decongestion of the camps, calling for those that are most at risk from COVID-19 to be moved as part of a shielding strategy. And thankfully, in April, the Greek government announced that they would move all migrants at risk from COVID-19 to hostels and hotels on the island, as well as their family. But at least 600 people identified remain on the islands due to restrictions linked to their migration status. And the government also implemented, whilst neglecting the health response, implemented months-long lockdowns, well beyond the lockdowns for the general population. And on the 2nd of September, the first confirmed COVID case was identified in the Moria Rick on Lesbos, and quickly mass quarantine of the hotspot was implemented. Only a few nights later, on the 8th of September, fires broke out in several parts of the Moria Rick, starting near the COVID isolation area that completely destroyed the camp, leaving thousands of people with no shelter for 11 nights. I think it's important to note the European Centre for Disease Control guidance on COVID-19 in reception centres does not recommend mass quarantine of entire facilities. It states that there's no evidence this effectively limits transmission and may be counterproductive in settings where prevention measures cannot be appropriately applied. But despite this recommendation, the Greek authorities continue to apply mass quarantine measures in reception centres, and we see the use of coercive measures specifically used against migrants. Finally, MSF also responded to migrant workers and migrants living in precarious settings. Migrants living in precarious settings are often neglected or not included in the national health response. Building on Tom's presentation, many of these migrants have no rights to any of the social protections that exist in these countries or the social recovery programs due to their legal status. MSF responded to migrants living in shelters, squats and homeless shelters in cities such as Paris, Rome, Manaus, Joburg, Beirut, and Brussels. In these cities, we often worked with local NGOs to support the continuation of essential services, such as distribution of NFIs, and supported in the health promotion, sometimes through digital platforms like Facebook and WhatsApp, and conducted training and assessments to implement IPC in shelters, as well as bring testing to shelters. MSF conducted mobile clinics and established phone hotlines to continue medical assistance for migrants. And in Brussels and Paris and Manaus, MSF established COVID-19 isolation centres for migrants and other people living in precarious settings to have a space where those that were symptomatic with COVID-19 can safely isolate. In the United States, for example, in Florida, where there's between 10 to 20,000 migrant farm workers that had to continue working in agricultural farms during the pandemic with no access to healthcare and testing, we worked with the Coalition of Farm Workers and the Department of Health to provide mobile virtual clinics and remote consultations, as well as COVID testing to this group specifically. So to truly leave no one behind, we must do, as Tom said, the basics better. So that means that all migrants and refugees must be included in national and global response plans to COVID-19, as well as social recovery plans. Refugee and asylum seekers should not be stigmatized or painted as a threat during the time of COVID-19. And adapted measures to reach communities, especially those in informal and precarious housing, should be implemented. And these policies should not be punitive, but instead work with NGOs, volunteers, and other frontline workers. We must, and this is the opportunity, to really truly implement universal access to healthcare to all. And we must also ensure that there's no conflation between public health agendas and deadly migration control policies. Thank you.
Thank you, Reem. Excellent presentation. And a reminder, I think, on top of the indirect impacts of COVID in terms of economic and health issues, as Tom highlighted, you've brought in the instrumentalization of COVID to justify oppressive measures against excluded and vulnerable populations. And I think this will be another of the key issues that maybe we can discuss further later on. Okay, so we're now moving to our final presenter, and keep the questions coming. We'll be having plenty of time for those. Our last presenter is Lucas Molfino, who is the Deputy Medical Director with MSF Operational Center in Geneva. And he's going to present on the COVID-19 related challenges and adaptations of humanitarian response in Lebanon, in both urban areas and refugee camps, through his last fieldwork with MSF in Lebanon. Please go ahead, Lucas.
Hello, everybody. Thank you, Tom. Can you hear me?
Loud and clear.
Okay, so I will start to share my presentation. Okay, and now is, so now I need to find how to do it in, okay. So Reem is not the only one that you have problems. You can see that, you can see the slide?
Hi, Lucas. If you go up to slideshow.
Slideshow, yes.
So,
oh, yes.
okay,
yes.
change your display
yes.
settings. And you should be good to go from there.
Okay, everybody see?
Yep.
Okay, well, thanks again. So here we go. So I will try to share my experience. So I was in Lebanon for almost 1.5 years, from 2019 until October 2020. I will try to share how MSF contribute to the COVID response, to the overall COVID response in Lebanon. I think that it's important to, well, for those who are not aware, Lebanon is a tiny country in the Middle East, quite strategical due to the relationship with the region and also the relationship to the West. The current population is around 6 million people, with a significant, well, number of refugees living in Lebanon, almost 1.5 displaced Syrians living in Lebanon since the beginning of the Syrian crisis in 2011. Almost 220,000 Palestinians as well living there, Palestinians coming from Syria as well, and Palestinians, well, that has been moving to Lebanon in the last decade due to the conflict between Israel as well. No? So Lebanon in the last couple of years has been experienced several crises at the same time. I think that there's a huge impact of at country level, at every single level of the Syrian war. Since October 2019 has been a massive political, economical crisis in Lebanon. The economy is in a free fall, and that have a huge impact at every single level. And of course, after that, we have the COVID pandemic. And for I guess that all of you are aware of the massive Beirut explosion at the port that took place in August of 2020, who have also severe consequences, especially on the health system. I think that it's important also to mention the unique characteristic of the health system in Lebanon, quite privatized, fragmented, much more oriented to curative intervention, let's say, rather than preventive approach. And and how the economical crisis was already impacted in the health system due to access to service, because health is a commodity in Lebanon. Basically, you need to pay for it. And how impact also in the supply chain due to the lack of drugs or the consumable material due to the liquidity problem. I think that this is important to keep in mind, because this multi-layer crisis or simultaneously crisis between the impact of the Syrian war, the economical crisis, and the blast have a massive consequence on how we altogether respond to the COVID. MSF is present in Lebanon since 76. And here, sorry for the acronym, and I will go through. So the scope of the project to date are mostly related to primary health care and secondary health care. So we go from primary health centers up to hospitals, and mostly of areas of intervention are related to non-communicable disease. So keep in mind hypertension, cardiovascular disease, diabetes, sexual and reproductive health, with family planning, antenatal consultation, postnatal consultation, maternities, mental health, and pediatrics outpatient department. We have also a couple of maternity centers across the country. There's a quite interesting project of a pediatric intensive care unit in the Bekaa Valley. So you can see the different points where MSF have different projects, clinics, and hospitals. I think that this is to set up the frame and how so we can keep going. So the first case of COVID was shown in Lebanon on the 20th of February of 2020. I think that in all the Middle East, the COVID cases start to be related to the religious migration to Iran. And after that, when the people were coming back, I think that will start to spread COVID in the whole region. Traditionally, the government of Lebanon set up the coordination platforms. I think that the response was organized based on the WHO strategy with the 8 pillars, and taking some lessons from other countries who were responding in the early phase. Initial lockdown, the close of the airport, close of the borders. The initially response plan was very centralized in Beirut, with the testing and the case management. That was important. And since the very beginning was, several gaps in the coordination, especially gaps in the response to the vulnerable population, as Reem was mentioned, the refugees, prisoners, elderly, domestic migrant workers. I think that from the MSF side, we try to contribute. We were part of the overall response, and this is more or less the strategy that we set up in the response, with a strong input on the community engagement, early identification of cases. We were thinking in isolation capacity, support to a Ministry of Health hospital, and if necessary, to set up a field hospital especially focus on the Bekaa Valley. I think that there has been a few transversal areas. I think that mental health was a key component in all the areas. I think that keep in mind that Lebanon was coming from a huge economical crisis with depreciation of the currency, and that was having a huge impact on the daily life of people. Almost from one day to another, almost 2/3 of the population of Lebanon became under the poverty line. And as Reem was mentioned, key action from our side was also focused on the advocacy side in order to ensure access to the most vulnerable. So you can see the difference level and what were the objective of different intervention. So the reduction of the transmission, mortality and morbidity, and also how important was the continuation of essential services. And now I think that we can break down a little bit per level. And I think that the most important was the adaptation of our routine activities. For us, was fundamental to keep was a priority for MSF to maintain the essential services. But of course, business cannot keep doing as usual. So what we were doing was we introduced COVID triage posts and referral path to the treatment centers and the testing centers. I think that also we reinforced the IPC measures, and we set up COVID awareness health talks. inform the people, giving information to the people what to do in case of. But also the COVID gave us the opportunity to introduce a new way of working in our regular service. We will reschedule appointment. We will give an extra medication to the people, especially those who were not communicable disease, who were stable. So we provide an extra couple of months of medication. We set up alternative way of distribution of medication with the focal points at the community. We introduced the proactive phone follow-up for diabetes patients who were using insulin, for mental health cases. We reinforce also our sexual and reproductive health intervention, especially the family planning. But of course, few service has been put on hold, especially the surgery one and the vaccination, and at least for the first couple of weeks. Then for us, the most important was the community engagement. The community engagement was composed by different things. What we did first was set up a quick surveys to try to understand what the population was understanding, if COVID was a real concern, the health-seeking behavior of the people, what the people believe about isolation, self-quarantine, the shielding, these type of things. After that, we set up health promotion strategies. We come with a clear network of focal points at community level, in urban settings, in refugee camps, in rural settings. We piloting the shielding. So basically those people high at risk, especially our NCD patients with high risk of cardiovascular disease or diabetes, we create this concept of shielding. And also we work together with different people and different organizations related to the frontline workers. Basically, we were targeting people who were at the front line, taxi drivers, Uber drivers, police, people in the supermarket, the people in the gas stations, in order to share with them, to create awareness, to identify prevention measures, what to do in case of suspicion of COVID, to train them in what it means, isolation, quarantine. This was a very interesting experience. Then the second level of the intervention was the early detection, and here is what Reem was mentioned. We were trying to secure access for testing and case management for the neglected communities, especially in the Palestinian camps, the domestic migrant workers. So we set up testing campaigns and in all these settings. I think that this was the most important. We set up mobile teams that were in touch between the community focal points and ensure the follow-up of the suspect cases and the COVID cases. And well, that same focal point to set up some kind of community surveillance for early detection, contact tracing and testing, no? So for Lebanon, for a long period of time, we were in phase 3, what the WHO was saying phase 3, so cluster of cases. So that early detection, the contact tracing and the testing was extremely useful. Then for overcrowded setting, we come with the idea of the isolation centers. We were thinking at the very beginning, long discussion at Lebanon about the setting isolation sites. So everybody COVID positive should be isolated in a specific size. After that turned a difficult and complex discussion because the capacity to run in these isolation centers. So we were much more going to the home isolation, but in those overcrowded settings, especially the refugee setting, the refugee camps, we were set up 2 big isolation centers that we can delocate the people who have not possibility to self-isolate at home. And after that, we support the MOH hospital with the donation of material, trainings, IPC measure, with the idea to the hospital to keep providing essential services. During the first wave was not necessary to set up the MSF hospital, but during the second wave in late September, MSF opened the Bar Elias Hospital, who is a field hospital focused only on COVID. I will not talk much about advocacy as Reem mentioned most of the points. The mental health was as a transversal activity through all that, and or staff health as well to provide IPC measures and to take care of our staff was also a fundamental thing. Here you can see different pictures. You can see the frontline workers training, how we were working with the police, with the security forces, how the focal points at the community were working, the health talks at community level, the shielding with the NCD cases. I think that we can say that the main challenge that we were facing was, well, the gaps in the coordination between central level, local level, and the different sectors. The measures that we were putting in place, the government was putting in place, was much more reactive than proactive, and the lack of compliance. I think that everybody talked about the economical impact of that. In Lebanon, most of the people need to choose between die of hunger or dying of COVID. So there's a little bit lack of compliance on the lockdown measures. The impact of the economic crisis on the health system. There's no money to pay staff. Many services at different hospitals were closing down. There's no ICU bed. Weak and fragmented information system. This is a very interesting challenge. We are completely failing to have a accurate epidemiological modeling. I think that at the very beginning of the outbreak, we were planning we were trying to do a modeling together with the different actors, WHO, Ministry of Health, about how there could be the impact of COVID on Lebanon, on the different settings. And we were using the model of Italy, the model of China, those that available at that time. But the epidemic followed a completely different trend in Lebanon. Well, the limited availability of supplies and equipment has been mentioned by my previous colleague, and sometimes we were facing limited community awareness. I think that the key message that we learned is like continuation of essential services at paramount was fundamental, ensure access to healthcare for vulnerable groups. Community engagement and early COVID detection activity play a key role, especially in the early phase of the epidemic. COVID as an opportunity as well to introduce innovation and to introduce new model of care in the health system. And I think that I can conclude that, well, I think that the COVID also gives the possibility to Lebanon maybe to reshape the health system. I think that would be important, much more focus on preventive, on community, and on primary health care than focus on hospital and curative service. So I think that that's all from my side.
Thanks a lot, Lucas. Wow, what a rich set of presentations, and we have many questions coming in. So we have about 40 minutes left. We're running a little over, but I think it was worth it to get all of these amazing presentations in. So thank you to all of the panelists. And now we're going to, I'm going to pick through some of these questions. I have a team helping advise me on which presentations, particularly to which questions bring out the themes mostly. And just a reminder from Lucas there on another of these areas of equity, the fact that in wealthy countries, shielding is possible, but the idea that people at most vulnerable in settings like Lebanese refugee camps are able to stay at home and to manage without somebody providing for all of their daily needs and to protect themselves from COVID raises huge questions for how we can ensure equity of protection against COVID in different settings. So now I'd like to start, let me just pick a question that we had fairly early on. This is a question from Stephanie Sodero asking Janet and Tom about the issues of scaling up of medical oxygen distribution. If any of the panelists would like to respond, that's a possibility, but perhaps first to Janet. And the question is also asking about key barriers and opportunities. And I think, as Janet said, keep at the beginning doing the basics well. The question of whether oxygen is a basic, a minimum, bearing in mind that most of rural Africa does not have access to oxygen, raises huge questions around how we can scale it up. But it also raises questions of what the basic access to oxygen is, what level of oxygen flow, and even, as Raji showed, whether it includes ventilation and access to high flow oxygen. So Janet, let's see how you can answer that question.
Thank you, Tom. It's an excellent question, and we've been thinking about this quite a bit here. So it's a timely question. So one, oxygen is on the essential medications list, so it must be clear that WHO did put it on the EML list, which means it should be available medical oxygen for patients, not just for surgery or for trauma or for maternal and child health, but for all patients that may need oxygen for example, for COVID. So that's one thing. So second thing is, but what are the challenges and what are the opportunities? What we've learned is that one, the knowledge at country level is varied. Doing the assessment of availability and accessibility of oxygen at country levels is not very well done. So actually knowing where you're starting, what is the starting ground of your system at country level, I think needs to be worked on, because you don't know the scale of your problem in details unless you've got a good assessment, because the solutions come from understanding where you're starting from. And the solutions tend to have to be customized to some level. And I want to be clear with that, because you have to decide, country has to decide and have a strategy of how they want to scale up. So what is the need? How many beds do I want to give oxygen to? How many patients do I want to treat over time? How much oxygen needs will they actually, what are the requirements? Like how much flow of oxygen do you need? And with that, you can make a calculation to estimate what is the sustainable solution. So how much liquid oxygen, if you're going to go with that route, do I need to purchase? Or if I'm going to put in a concentrator that you saw the photo, what size PSA? And that's the name of the big concentrator device. It's called a pressure swing absorption device. But how big does that need to be? How much cubic meters of oxygen does it need to produce? And so that's a technical question, but it needs to be determined. And then how am I going to distribute it? How am I going to pipe it into the hospital beds, which may be the best approach? Or am I going to fill cylinders and then decide to distribute cylinders to an encatchment area? So these are questions that need to be done and customized to your setting, as well as, and then enacted and operated on. And what that requires is sufficient technical expertise on the ground and sufficient funding for sustainability. And I just want to give the example here. Let's say these PSA plants, if you decide to go in that approach, then the life cycle of that concentrator can be up to 20 years. And so that's a long time that it can provide, independent production of oxygen. Now, in order to maintain for 20 years of a good PSA plant and good functioning, then you do need the long-term service agreements. You do need enough technical competencies in order to maintain it. And these things can be done. So what we've learned with our consultations is that it's a multidisciplinary approach, right? And it has to engage both, you're dealing with the manufacturers that supply the components, the technical expertise, the donors that someone's going to have to financially invest in this, and then sustain it. So I think there's many opportunities for finding solutions. There probably has to be better business models of how to implement sustainable oxygen systems. One of these PSA plants, for example, can take up to 3 months, the lead time in order to get this in the field. How do you facilitate procurement, installation, maintenance, et cetera? So I think this is a must happen, and we have to figure out globally amongst all the organizations and to support ministries, especially the ministries of health that may be having more challenges in scaling up, to find customized solutions in order to be able to provide patients with sufficient oxygen. So thank you.
Thanks, Reem. Raji, would you like to answer? Please be brief. And those panelists, if you're not wanting to answer this particular question, can you put your video off? Then it helps me to know who wants to engage, so we can try and get as many questions in. And a reminder to the attendees that many questions have been answered in writing, and we won't have time to go through all. So later on, please do make sure you look at some of the responses that the panelists have given to the questions. Raji, go ahead.
All right, thank you, Tom, and thank you, Janet, for those answers. So what we did as Africa CDC was to map the oxygen or the critical care capacity on the continent. And after that mapping exercise, we came up with what is a short-term approach, because patients are dying. What do we need to do immediately? And what is a medium to long-term approach? So for the short-term approach was to support member states with oxygen concentrators, especially those fragile and vulnerable member states. And we are happy to see that that actually worked, because in addition to supplying them with these oxygen concentrators, we also back this up with training, capacity building. And for the long-term measure, we are working with different partners to make sure that in each and every region on the continent, we have oxygen plant established that will be able to support the different member states. And we are leveraging on the capacity of the African Continental Free Trade Area to make sure that oxygen, as far as each and every member state, it's available and is also affordable. Over.
Okay, thank you, Raji. And Tom, did you have your video on there wanting?
Yeah,
Go ahead.
yes, it was very, very brief, just to make the point that if we are considering implementing things like oxygen, obviously it would be great to think beyond COVID-19 pandemic and for long-term use and how that was going to be sustainable. That was my only point.
Okay, thanks very much. I think I'll jump to another set. Leon S. has raised a set of basic questions at the other end of things about the engagement of communities and the difficulty of mobilizing communities. So I wonder if any of the panelists would like to respond to that, about their how they see the issue of engaging communities in the response, and what particular difficulties they've had in humanitarian settings, or that they see. Perhaps that could first of all go to Reem or to Lucas.
Yeah, maybe I'll touch on that just briefly. I think there's twofold in this. One, I think actually one of the bright spots in this pandemic has been, the role of community and community mobilization, especially in terms of mutual aid. So we talked about the lack of social protection safety net. Oftentimes this has been overcome by mutual aid strategies at a community level of, organizing food distributions, NFI distributions, and various other protections at that community level, which has been, I think, one of the few bright spots this year. On the flip side of that is that you have, with these kind of increased in lockdown measures, and particularly in some places, particularly the coercive measures that are tied to that, which is the extreme policing and the fines, it kind of is it increases the risk for communities, especially those that are more vulnerable communities or criminalized communities, such as undocumented people, to be visible in terms of supporting their community members and have that. So I think, one of the things we've seen in this pandemic, whether we agree with I think we all agree lockdown measures are an important element, but I think the level of coercion and policing has been a deterrent in terms of trust, particularly when we're looking at marginalized communities, and then also a deterrent in really emboldening and reinforcing that community mobilization.
Maybe.
Okay, Lucas, go ahead.
Yeah, so maybe just to add on what Reem was saying, I think that for us was the backbone of the intervention since the very beginning. We took time to understand how to engage with the community. Well, I briefly mentioned the different type of surveys that we were doing to understand. But basically, the idea was to have a clear understanding if the people were concerned about the COVID, the health-seeking behavior, the belief, the acceptance, what they think about the isolation, self-quarantine, these type of things, I guess. And after that, we come with the health promotion strategy, with the idea of having focal points at the community. And that we realized that enhanced solidarity between the community, as Reem was mentioned. We set up some kind of mechanism of community surveillance system in order to early detection for suspect cases, and to ensure access to testing and case management if needed. And in case of home isolation and self-isolation, how the community can contribute to that. But for us, the engagement with the community was fundamental. Was not easy. In some places we have a stigma. We have, I remember visiting one refugee camp in the north and saying that, discussing with some of them, and they were saying like, we have chemical weapons over us. We are not going to be afraid of COVID, you know. So at a certain point, you need to put in perspective the COVID and how to engage with the community. Was extremely interesting, but again, was fundamental for us, the community engagement.
Thanks, Lucas. And I would just add that across South Africa, there have been hundreds of community groups set up called COVID-19 implementation and activist groups engaging within their communities. And one of the big questions has been how to support this indigenous response in accessing essential information or supplies and coordinating. But I think it's a really critical question for all of us engaged in the response. Now, I don't see any other videos open wanting to answer that, so let's move on. I have a question to Reem. Now, one second, I'm trying to flick through. Reem, you indicated that you would like to answer one of the questions live, so if you have it there in front of you, perhaps you can read it out and answer it yourself.
Yeah, I'll also like Lucas to build on this, and maybe you as well, Tom. But the question is, the pandemic has brought different sets of challenges, right from sending aid workers back to their homes, to not increasing the burden on local authorities, to facing funding cuts. How difficult and easy is it to secure resources for addressing COVID needs of specific populations in specific humanitarian contexts, while the general population was in similar need? And I think this question is really interesting because it's, you know, this, how can we justify having responses for smaller groups of vulnerable people when we're in this global health pandemic? So just to be clear, in the examples for migration projects that I highlighted, responding to migrants was only part of our intervention in all of those countries. So for example, in Belgium, whilst we were responding to migrants by building the isolation center, also there was part of that response also included homeless people, but we were also working in nursing homes and with hospitals at the same time. And I think what this really shows and demonstrates is, and I think what this pandemic shows and demonstrates is that the health of our society is very intertwined. So actually, without states and also NGOs specifically having adapted projects for specific groups, which might not actually take that many more resources, and leaving them out of the general national response, this is leaving massive, you know, black holes in the pandemic response overall for that country. So I would kind of flip that question and say it's actually essential for the general population and the general response in terms of the COVID response, to make sure that we also have adapted projects to specific populations whose needs are potentially different in some ways than the general population.
Okay, thanks, Reem. Lucas, would you, or any other panelist, would you like to add anything to that?
What just Reem said, though, for us was important because even if there's a general framework for the COVID response, there are some groups who was left behind, especially in Lebanon, where you have all the UN agencies working with the government of Lebanon in addressing the problem of the refugee, but there are some group that was really behind, who was the domestic migrant workers. I think that some of the people mentioned about that, domestic workers, people from West Africa, from East Africa moving to Lebanon to work, but also we have a huge group of Asian people who is working in the construction and who were very invisible then, and we will put in we were working with them, we will secure access to healthcare, to testing, to case management, because some of them were the active cluster, you know. So I think that as Reem say, you know, by working with the local associations and reshifting or activities, we highlight this and put them on board as well. Over.
Sorry, I'm just switching around my.
Maybe I can reply a few quickly question about the vaccination. For us was of course was a extremely essential service, but we will have limited resources, and was fundamental to reorganize our service. You know, to, as I mentioned before, to put the properly IPC measures in place, to reallocate the staff, to provide the properly equipment to our staff. So from the moment we were putting some service on hold, but was immediately as possible, we would just to re-engage on that service. That for one. And when I'm talking about the COVID, to give us the possibility to innovate and to do things in a different way, I'm thinking in innovation in a way to do things in a different way. Let's say, as I mentioned also at the beginning of my talk, how the complexity of the health system and how the model of care currently in place in Lebanon. So COVID gave us the opportunity for the simplification of care, for the simplification of protocol, to empower the patient to be accountable to their own disease as well, and to treat the patient as a partner, you know. So to provide an extra month of treatment, to encourage them to take a decision by their own. We were implementing different methods, like the WhatsApp call to follow up the patient, the video call in order to see the face of the patient and interact with the medical people. That the digital health promotion was a massive achievement. I think that the COVID forced us to work on that through the social media, videos, Facebook, these type of things. This is what I mean about the innovation and new model of care. Over.
Okay, thanks, Lucas. Okay, moving to a question around testing that perhaps for Raji or Janet. Saeed Ahmed is asking, in countries who don't perform enough COVID tests or don't have access to enough testing, and where, of course, most cases are not tested, what would be your approaches to scaling up case detection? Or perhaps do you think case detection with laboratories is necessary as part of the response in such settings? I'll put that to Raji.
Sorry, Tom, I just rejoined the meeting, so I didn't get the question.
So the question is essentially about the role of testing, bearing in mind the very difficult access to COVID testing in many parts of Africa, and the very long turnaround times of results. What's your view on scaling up of case detection and how to both increase access to laboratory testing, but also how to mitigate its absence?
Okay, all right, thank you, Tom. So as Africa CDC, I think one of the areas that we've made greatest impact is in the aspect of testing. So when we started this journey, there were only 2 countries that could do testing as far as the continent is concerned. So we embarked on training. The first training took place in Senegal, where we covered close to half of our member states. And the second training took place in South Africa. So in addition to the training, we also made sure that we supported member states with testing kits. Because as you rightly pointed out, one of the greatest challenges at the outset of this pandemic was access to these testing kits and availability of the testing kit itself. So we did make sure that member states also get this testing. Now, there were some few member states that do not have PCR, neither do they have the capacity to do PCR. So what we did was to repurpose GeneXpert machine. As you know, GeneXpert is one of those machines that have really done very well in terms of our TB control programs. So was to repurpose that, and we're able to talk to those traditional makers of gene expert machine to allow the cartridges from China to be used on those machines. So with their support, we're able to unlock their machine to make sure that we're able to use the cartridges on those machines. And with that, we were able to take each and everybody along as far as testing is concerned. And concerning the turnaround time, with more and more people, getting the necessary skill and knowledge to be able to run the test, I think this shortened the turnaround time significantly. So that's what we've done as far as the continent is concerned. And as I said, today we are over 20 million tests compared to where we started from at around 250,000 over.
Thanks very much.
Tom,
Lucas, did you want to add something? Go ahead.
Yeah, I think that a key role to play the rapid diagnosis test. I think that will be a huge achievement that is already available in order to decentralize testing capacity, and that will make a huge difference in low resource settings. So I think that we need to keep it now in mind that. Let's see how that fit in the different algorithm of testing, but I think that this is the way forward. Maybe Janet need to add something on that. Over.
No, just to agree. I think the take-home point is that we do want to make testing available. We do want to make it widely available, and the rapid diagnostic tests, as soon as we continue to gather more implementation research data on their performance, would be the best option. But we must strive for getting tests available.
Yeah, and I think it reminds us again of the difficulty of working out what the best balance between quality and feasibility is, when we know that rapid tests are far less sensitive than PCR. But if a PCR takes 3 weeks to give a result, it's useless in case management or in separation of transmission. So I think it's a really important question. Good to have it. Janet, while you're there, we have another question that came in from Michael Lurie. And I think he's raising this question for South Africa. What are the reasons for the disproportionate or the apparently disproportionate COVID-19 death toll in South Africa in comparison to other countries in Africa and elsewhere? Have a go at that one. And anyone else who'd like to join in, please put your video on.
Thanks. I just wanted to acknowledge that it's very difficult to compare mortalities or death tolls in different settings. I think the outcome of patients is complex to be attributed to one certain thing. We know that there's patient-specific factors which places them at higher risk for death, such as the risk factors that we are well aware of. We know that there's access to care issues, right? We do know if patients arrive late in their disease and they have severe disease, their outcome may be worse. Access to treatment. And then what treatments were given, actually, was someone being given with something we know that does reduce mortality, or potentially something that may have had more harm than good because it was unproven therapy. And then finally, the system that they're being cared for. And we do know, even in the most resource settings with, high, let's say a full capacity intensive care unit, that the mortality rates have been sometimes higher because of the surge, right? Because even when there was some number of intensive care beds or some number of staff available, that when the cases became so high, that the ability to care for those patients was less, and the quality of care potentially not able to be sustained. So I think it's a difficult question to answer because I think the outcomes are, like I said, related to multiple factors, both patient-related, care-related, access-related, and system-related. So thanks.
Thanks, Janet. Tom, go ahead.
Thanks very much for the question. So just to add to what Janet said, and also this is again from the UK experience, it's also highly dependent on what tests you're doing and how you're documenting and registering cases and indeed deaths. So a lot of the time when you're basing it on case fatality rate of the cases about how many are dying, that's wildly different when you scale up your testing and, for example, do testing in the community. And we've seen that throughout in different countries, but here in the UK, our rates have been vastly different. So it may also be related to those factors. the documentation of testing, what testing is going on in the community, and the documentation of deaths.
Great, thanks, Tom. Okay, I'd like to move on to a question to Raji from Seyon Kim. He's asking about what efforts CDC Africa is making or has made to persuade countries to follow guidelines. I think it's a particularly interesting question, looking at what's happening in the US and Brazil, and by contrast, how African countries may have been much quicker to engage seriously. Although, just a reminder that in Malawi, the courts took the government was taken to court to block a lockdown early on in COVID, and the case won. The government was denied the right on humanitarian grounds to go ahead with a lockdown in Malawi. But Raji, perhaps you could have a go at that one. How is CDC Africa working with countries to try and ensure adherence or engagement with guidelines around COVID?
No, thank you, Tom. So I think what we've been able to do is or what has really helped our member states is that of coordination. And this coordination is at both ministerial and at the level of the head of state. And this has really worked. Now, if you remember very well in my presentation, I talked about a task force that was put in place to drive or to implement the continent-wide strategy. So this task force is made up of members, is made up of scientists and experts from member states as well as Africa CDC. So whatever decision that is coming out of Africa CDC is a joint decision between the member state and the Africa CDC or African Union itself. So they are part and parcel of that decision. Number two, as part of our technical working group, we have a group that is looking at community engagement and risk communication. Again, so through that technical working group, we are able to get the necessary buy-in from the community before we even roll out any guideline. We also work closely with the different civil society organizations, work with different partners who have, different strengths, different advantages in the different parts of our member state. So with all this multiple approach, we were able to get member states buy-in. For instance, the issue of vaccine. When the vaccine discussion started, we actually made sure that we started from the community. And now that the vaccine is almost at the finish line, we have also finished our public perception survey as far as the vaccine is concerned, just to gauge what exactly are the community saying about this vaccine so that we can use the finding from this survey to inform our vaccine strategy as a continent. Over.
Thanks, Raji. Move to a question from Saikat Rana around assuming, and it looks as if we will have a COVID-19 vaccine available, at least in wealthy countries, fairly soon. The question is to MSF, will MSF provide COVID-19 vaccine to the patients? But I think the broader question is, how would you ration access to this vaccine, and what efforts can be made to maximize access to a vaccine? Would anybody like to answer that? Brief answer, either from MSF or from others on the panel. Raji, go ahead. A brief answer, please.
Yeah, I'll keep it short. So for Africa CDC, we have put in place Africa's COVID-19 development and access strategy. So in terms of who go first, so we have also tried as much as possible to come up with a priority list, which is not different from what COVAX facility is talking about. So this is essentially the frontline social and healthcare workers and the vulnerable groups. That's the elderly and people with underlying medical conditions. So these are the people to go first. And of course, others will follow. Over.
Any other one wanting to engage with that? Sorry, I've lost my video of the panelists. I see somebody there behind another box. Lucas.
No, just, well, it's a complex discussion, the vaccine. So it's especially with all the vaccines in the pipeline, with the efficacy, the logistic that will be necessary to roll out the vaccination, the cost as well. the role of MSF, that is a quite huge internal discussion inside the organization. You can contribute to the response, Tom, as well, or from your side. Well, I think that, well, there's different platforms that will secure the access to the vaccines to low-income countries and middle-income countries. Let's see how we can work together with the Ministry of Health and across the globe. And I think that a priori that will be the role of MSF, yeah, to accompany this process. I don't see if MSF is going to organize COVID vaccinations, but let's see, it's too early to say that.
Thanks, Lucas. Okay, I think we have time for one or two more. Just a question to Janet, but also to others on the panel. This is this question's coming in a variety of different ways, and it's to do with ensuring that the response to COVID is not seen as a vertical, isolated response, either in terms of funding or in terms of delivery. But the specific question is around how could governments and NGOs and others do more towards integrating COVID screening with other screenings at community level. But I think we could take that broader, whether it's screening, triage, treatment, prevention. What should we do better in terms of ensuring that COVID is not treated as an isolated issue?
Thanks. It's an excellent question, and it's not complicated. I mean, it's complicated, and at the same time, maybe not so. I do think we have to look outside of the vertical silos. That we are going to be living with COVID. You know, circulating. It is circulating now, widespread in communities in many places. And so the health system needs to find an integrated approach to caring for COVID. And so now what we've done, correctly so, is trying to make the COVID care pathways, but in some countries that has been distinct facilities, right? Separate areas, separate treatment facilities. And now the question is, in your health system, how will you arrange now your new hospital, right? I think people have been talking about like not the future hospital or the safe hospital, but like, how do we now have a hospital that is structured in an architectural way or refurbished in a way that there's a way that we can manage patients with COVID, just like we were managing patients with influenza as well, right? Which our systems see every year when there's a circulating influenza, seasonal influenza. So how do we deal with COVID then in an integrated way? How do we make sure our hospitals are safe enough to care for those? And I think part of that is the IPC and the ventilation and the care pathways. How do we ensure that the system has enough, therapeutics, whatever they may be, now and in the future, to care for those patients? So I think for ministries and for partners that are in the field doing operations is to kind of help start to integrate COVID care into regular care, knowing that it will be here, and then to develop care pathways that are integrated into that system, and then supply chains and staff training, everything in order to be able to cope with COVID-19 as it continues in the future. Over. Oh, and then one other thing is, I guess maybe putting into like the healthcare system readiness. I think that's one of the terms we've been using here at WHO, and kind of keeping the healthcare system, so then it becomes a system ready for COVID or ready for another emerging infectious disease, and maybe looking more broadly that way.
Thanks, Janet. Okay, I'll ask one last question coming from Maya, which is, I think, an interesting and two-sided one. The question is put to MSF. What is the financial impact of COVID-19 for MSF projects functioning? Are there budget consequences, less donations? So how's it impacting? And we know that sometimes big visible emergencies for NGOs can have quite strong positive, in inverted commas, impacts on funding. So it'd be interesting, Lucas, perhaps you could answer that, but also remembering and seeing Zambia is just defaulting on its international debt because of indirectly the impact of COVID. We're likely to see governments reducing their funding to health as they try to continue servicing their massive debts. So Raji, I would just wonder if you could also comment from a government perspective on the financial impact of COVID in ensuring that health systems are able to respond. Go ahead, Lucas.
Okay, Tom, thank you. I don't have the global numbers of MSF in general, of the whole movement. I can talk on behalf of the operational center Geneva, but so far we were able to respond to the COVID emergencies, especially in those settings that we were working, and COVID became a real problem. So we were able to do that. Even MSF was able to respond. As Reem was mentioned, in Belgium, also we respond in Switzerland as well for targeting the most vulnerable as well. So far, it has not been a concern, the financial situation for the moment, and I don't have in mind if donation increase or decrease related to COVID so this is what I can say, so little. Sorry.
No worries. And Raji, would you like to make any comments on that?
No, thank you, Tom. So, and thank you for the question. So what the Union, the African Union, again, this is an issue that has been raised at the level of the head of state and government under the leadership of President Cyril Ramaphosa, working with our development banks and working with different member states to see how do we define payment. How do we build the capacity of the two main development banks, the Africa Import and Export Bank and Africa Development Bank, so that they're able to provide more support to member states? Number three is to work closely with World Bank to also see how would they be able to support the different countries. Of course, number five is to continue other essential health services other than COVID, the need for us to continue to run those services so that it's not just about COVID, it's also about non-COVID issues, which will also have significant impact. And of course, last but not the least is the campaign that we have just launched, that this continuous lockdown is not something that is going to work for us in Africa. We just need to look for a way of opening up, but we just need to do it safely. So this is what we have done as a continent, and we are looking at how this is going to assist our member states. As you all know, just 2 days ago, Nigeria went into recession. So we know that this is something that is biting hard. But we believe that with this initiative from the head of state and the special envoys that have been set aside to work on this, I think Africa should be able to navigate that very, very difficult terrain. Over to you, Tom.
Okay, thank you very much, Haji. And I think with that, we will draw this fascinating session to a close. As Al-Haji has sent his thanks to the organizers and panelists, the session is very rich in information, very, very rich indeed. And there are many questions that we didn't manage to answer. So the panelists will carry on hopefully answering typed to your questions, and please find time to read them. But I'd like to thank all of you and all of the panelists. We're living through an incredible moment, and it's great that you have been able to join this and are engaging with the LEAP course at this critical time in understanding what humanitarianism means as COVID shines. It's a hackneyed phrase now, isn't it? COVID shining a spotlight on the failures of the international system. But frankly, it's shining so many spotlights. There should be no place to hide in terms of the inequities underlying people's denial of access, in terms of the inequities undermining people's ability to manage their own risks and to get access to treatment. And fundamentally, that COVID is no different to any other infection for all its uniqueness. But in this moment, it's giving the whole world an opportunity to, facing the same problem everywhere, try to understand how we can improve the global health system and perhaps even the global political system and the world. So I hope that you have taken something away from this. I hope that we can make sure that this spotlight is maintained, both to highlight the threat that COVID is, but perhaps more importantly, the opportunity that it allows us to rebuild health systems in a way that is fit for purpose. So thanks to all of you for joining. And thank you to the panelists, and hope to see you all again at some future LEAP event. Thanks very much to everyone.